Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the Ultimate USMLE Step 1 Review. This is the second edition of the book, and we're going through it chapter by chapter. This is part 6 of the Neurology chapter. We're going to start by talking about movement disorders. These are neurologic disorders characterized by various abnormal or dysfunctional movements. Chorea, for example, is a sudden, jerky, purposeless movement generally seen with lesions to the basal ganglia, which can evolve into athetosis, which is a slow, writhing movement, especially of the fingers. In contrast to other movements, hemibolismus is a sudden, wild flailing of one arm caused by contralateral subthalamic nucleus lesion. Other movements can include myoclonus and dystonias, which are sustained involuntary muscle contractions. Parkinson's disease. Parkinson's disease is a degenerative disorder of the CNS in which the dopamine-producing cells of the substantia nigra in the midbrain undergo cell death for unknown reasons. It has been postulated that the accumulation of Lewy bodies, alpha-synuclein intracellular inclusions, and its progression in location from brainstem to the cortex plays a role in Parkinson's disease development. Referring back to the basal ganglia section in physiology, keep in mind that dopamine plays a significant role in motor movement modulation. In general, high dopamine levels promote motor activity, whereas low levels, such as those in Parkinson's disease, decrease it. As a result of the loss of dopaminergic neurons, patients develop a collection of motor symptoms known as Parkinsonism. Classic symptoms include rigidity, bradykinesia, akinesia, postural instability, and tremor. Other common symptoms include a festinating, shuffling gait with decreased arm swing and turning end block, hypophonia or soft speech, micrographia, which is small cramped handwriting, and hypomimia, which is a mask-like emotionless face. In addition to motor symptoms, patients also develop sleeping difficulties. REM disorders precede motor findings, as well as neuropsychiatric symptoms affecting mood, cognition, behavior, or thought, such as depression, apathy, and anxiety. Similar to Alzheimer's disease, primary idiopathic Parkinson's disease is diagnosed clinically with a medical history and neurologic examination. When dealing with a patient with Parkinsonism, secondary or acquired causes must also be ruled out. Methylphenyl tetrahydropyridine, a contaminant in illicit street drugs, can cause selective destruction of dopaminergic neurons, whereas drug-induced Parkinsonism can result from antipsychotics, such as haloperidol, because of dopamine D2 receptor blockade. Parkinson plus syndromes are conditions in which Parkinsonism exists with some other dominating feature. For example, multiple system atrophy, also known as Shy-Drager syndrome, is a combination of Parkinsonism, ataxia, and autonomic dysfunction. Progressive supranuclear palsy, or PSP, is a combination of Parkinsonism with predominantly visual symptoms, especially the inability to move the eyes vertically, causing early falls. Huntington's disease. An autosomal dominant neurodegenerative genetic trinucleotide repeat disorder. The Huntington gene on chromosome 4 contains a sequence of CAG, glutamine, that is repeated. This polyglutamine sequence normally consists of fewer than 36 repeats in normal individuals. Once it is 36 or more repeats, the Huntington protein possesses different characteristics and is considered a mutant form. This mutant form leads to neuronal death via NMDA receptor binding and glutamate excitotoxicity. Patients typically present with a triad of early dementia, ages 20s to 50s, behavioral changes such as emotional lability, aggression, or hypersexuality, and choreiform movement. CT scanning of the brain generally shows atrophy of the striatum, which consists of the caudate nucleus and putamen. Once the disease is suspected, genetic testing is crucial in confirming physical findings, and providing the patient with genetic counseling is crucial. The trinucleotide CAG is unstable during replication, and its instability increases with the number of repeats present. As a result, genetic anticipation is seen. With each successive generation, the numbers of repeats increases, along with the severity and earlier onset of Huntington disease. There is no cure for Huntington disease, and symptoms are treated as appropriate. Friedreich ataxia, an autosomal recessive inherited disorder in which trinucleotide repeats, GAA, lead to decreased transcription of the frataxin protein. As a result, mitochondrial dysfunction occurs because of free radical damage from cytoplasmic iron buildup. Patients present from the age of 5 to 30 years with signs and symptoms such as kyphoscoliosis, ataxia, a wide-based gait, dysarthria, slurred speech, nystagmus, and high plantar arches, or pes cavus. Patients develop heart disease, such as conduction defects and cardiomyopathy, as well as diabetes. Death is usually secondary to hypertrophic cardiomyopathy. Dementia is outlined extensively in Table 13-6, and it's an irreversible global decrease in cognitive ability beyond what is expected with age. It is important to differentiate it from delirium, which is often reversible and waxing and waning. Further differentiation is discussed further in Chapter 14. Before making the diagnosis of dementia, other organic causes must be ruled out, such as syphilis, HIV, vitamin B deficiency, Wilson disease, and hypothyroidism. Seizures. A seizure is an episode in which there is an abnormal excess of synchronous neuronal firing that leads to transient symptoms, such as tonic-clonic movements, behavioral alterations, or sensory alterations, for example, déjà vu, or a burning rubber olfactory hallucination. Many conditions can bring about an episode of a seizure, including hypoglycemia, hyponatremia, fever, delirium tremens, infection, stroke, and brain tumors. Epilepsy is a term used specifically to describe recurrent, spontaneous, unprovoked seizures from an underlying alteration of brain function. Epilepsy is a continuum of seizure disorders that differ in terms of clinical presentation, underlying causes, and pathophysiology, which is classified according to site of origin and pattern of spread. Partial seizures arise in a localized focal area of the brain, but can spread to nearby areas that can ultimately become secondarily generalized seizures with diffuse brain involvement. For example, a Jacksonian seizure starts in one area of the brain and moves along the motor homunculus. Typically, a Jacksonian march starts with tingling in the fingers, moving more proximally, leading to arm, head, and eye movements. Sometimes the seizure can cross to the other side of the brain, leading to a secondarily generalized seizure. Simple partial. Seizures present as motor, sensory, autonomic, or psychologic symptoms, depending on origin. Consciousness is not impaired. However, the seizure can spread, leading to a complex partial seizure or generalized seizure. Complex partial. A seizure preceded by an aura in which consciousness is impaired. Patients may remain motionless or engage in repetitive behaviors called automatisms. For example, grimacing or lip smacking. Although it may arise from any lobe of the brain, it most commonly arises from the mesial temporal lobe. Occasionally, mesial temporal sclerosis may be seen on imaging, indicating gliosis and atrophy from neuronal loss. Generalized seizures. Diffuse brain involvement that impairs consciousness. Absence. Formerly known as petit mal seizures, these are brief seizures of sudden onset and termination with no post-ictal confusion. Because this often presents with staring spells in children, it may be confused with attention deficit disorder. However, absence seizures may still have automatisms. EEG shows 3 Hz generalized spike and slow wave discharges. Treatment is mainly with ethosuximide or valproic acid. Myoclonic seizures, rapid involuntary contraction of muscles described as jumps. In juvenile myoclonic epilepsy, seizures begin between puberty and adulthood, where seizures affect the neck, shoulders, and upper arms. They generally occur shortly after waking. Tonic-clonic seizures. This is the most common form of epilepsy, formerly known as grand mal seizures. Episodes are divided into 2 phases, the tonic phase and clonic phase. It first begins with the tonic phase, which will cause the patient to fall down. Muscles suddenly contract, causing the extremities to be rigidly pulled toward or away from the body. Following this, the clonic phase consists of rapid muscle contractions and relaxations, causing convulsions. Clinically, the patient may be rolling on the ground with the extremities violently shaking. Atonic seizures, also known as drop seizures, in which patients have a brief lapse of muscle tone leading to drop attacks, and they collapse to the ground. These seizures must be differentiated from similar-looking attacks that may occur in cataplexy or syncope. When encountering a patient that presents with seizure-type symptoms, further history and physical examination needs to be performed to confirm if it was a seizure, and if so, what the underlying cause may be. Epilepsy versus metabolic versus tumor versus infection versus stroke. In general, the patient's age may shed light on possible causes. For children, it is typically genetic or infectious, febrile, which differs from adults or older patients in whom tumors and strokes are more common. That's the end of this section. In the next, we'll be picking up with headache.